Good morning, everyone, and thanks KSOS and Dr. Gopal for having me here. Is the mouse not working here? Hmm? Okay. Uh, Thanks once again. So, in this session where Gopal has written "enemy at the door," actually these microorganisms are enemies. They are normally present in the conjunctive flora also, and therefore a lot of preventive measures, have been advocated to kill these microorganisms so as to prevent the entry. And I personally believe wound construction is the one of the main thing which is very, very important. So it is one of the most dreaded, most feared, most serious, most devastating kind of complication which can happen, and mostly for no fault of the surgeon. Usual culprits could include, IV fluids or anything which goes inside the eye. And as I said, if patient has load inside the sac which has not been taken care of, it can cause. Why I call it a disaster is that if not managed in time or if not managed properly, then it can lead to consequences like this. Believe me, time is of utmost importance, and a lot of times we used to get, not now. Now I think everybody has become wiser. A lot of times we used to get people on topical drops or maybe sometimes sublingual injections. So phthisis is not a result today. Although cases are going down, but believe me, when a single case happens, this can be very, very stressful for the surgeon who operates. You see, surgeon who does not operate, nothing. He is in any case a very happy man. But if series of cases happen, it is a very, very maddening situation. So as I said, a lot of thrust has been laid on this pre-operative measures, which obviously include to rule out infections. And per-operatively, although betadine has level 1 evidence, but sterile instrumentation, good irrigating fluids, and I have deliberately underlined good wound construction because this, I believe, is one thing which is preventive against endophthalmitis. And whensoever wound is not good, suture whenever in doubt. Intracameral antibiotics have been increasingly being used nowadays because of very nice publication from Arvind Group by Harpriya. Lakhs and lakhs cases were done, and this got published in ophthalmology, and even American Academy adopted. But if preventive measures fail, then early diagnosis and prompt treatment is the answer. And once you diagnose, intravitreal antibiotics are the mainstay. And if they are done properly, injected early, and you are lucky that organs are sensitive, the results are reasonably good, provided you do it very fast. And you have to be lucky that organs are sensitive. Otherwise, you have to resort to vitrectomy or wait for culture sensitivity report. So key issues are always delay and delay. One delay is primarily because you may mistake as a TAS or not willing to accept that my case has developed endophthalmitis. A second delay is giving that appropriate treatment. So why should anybody differentiate TAS from endophthalmitis? Primarily because the pathogenesis of both is different and treatment is vastly different. In one, we load the patient with steroids. In other, we have to load the patient with antibiotics. So in TAS, we give steroids by all possible routes, but in endopht, we have to give intravitreal antibiotics. In TAS, in any case, we do not go inside the eye most of the times. So this is one example which was being treated as inflammation because of these multiple keratic precipitates and this plaque on the posterior capsule, but it turned out to be a P. acne infection. This was one patient, a young lady who had undergone RK. She was referred for vitrectomy, but this turned out to be pure inflammation. So this lady was treated only with steroids. So I'll just exemplify by a couple of cases that why should you knock off the enemy at the door, which Gopal said. This is, unusual post-op reaction, good glow as you see here. This patient, I suspected TAS only and loaded this patient with steroids from all possible routes, but took photograph, every day. and fortunately, this patient did recover good vision, media became clearer. This was that young lady which I was referring to. She was operated for RK long time back, then phaco she intervened. But based on this whitish dropping, I thought this is purely inflammatory phenomena because of surgical insult and treated with steroids. And gradually, this took 2 weeks for this lady to recover. This was one of my patient, who developed hypopyon on day one. This was a uncontrolled diabetic TRD patient who underwent a VR surgery, and operatively all vessels we found were sclerosed, and she underwent PPV. And first day, this was the picture. And notice that the IOP was 30. IOP in infection inflammatory is generally not high. Generally not high is because of the cyclitis element is generally on the lower side, whereas in TAS it may be normal or it may be high also. So this patient had diffuse edema. Hypopyon can be present both in TAS as well as in. So this patient I monitor very closely because I was really concerned for this one-eyed patient. You see gradually, only on steroids, topical treatment, this patient gradually improved and hypopyon disappeared and fundus glow also returned to this position. This was one of the old, patient where this patient had an eventful surgery. You see the lenses in the anterior chamber, diffuse corneal edema, creative precipitates, hypopyon, lot of old KPs. This patient had not received any interval injection, and we were preparing this patient for IOL explantation and vitrectomy, but I gave it a try. I gave it intravitreal vancomycin, and fortunately, you see the end result was this. So this patient, responded to routine. So the moral of the story was that we analyzed a lot of these patients. Only 30% patients in this paper used to have intrathecal antibiotics as a treatment. Most of them used to have only subconjunctival injections and parenteral antibiotics. So moral is, if patient has not received intravitreal and you are preparing this patient for vitrectomy, no harm in trying intrathecal antibiotics. Results can be good sometimes, provided the organs are sensitive. This one another patient, you see ultrasound showed full exudates in the vitreous cavity and Descemet folds, PRPL accurate. This patient again, I tried intravitreal antibiotics only, and fortunately this patient also recovered. There are patches of iris atrophy from the previous surgical insult. This was one of my patient again. We had operated this patient for giant retinal tear. With silicone oil inside the eye, this patient had pretty good vision, 6/9 vision. And I remember the next day was a holiday, so I did go to see this patient on the Sunday morning. And what I saw on Sunday morning was this. So, point to be emphasized here is that there has to be no delay treatment. So I had to rung up my home that I will be late by a couple of hours because Sunday itself intrathecal vancomycin was given. And fortunately, this was the result after a couple of weeks. Patient did recover back 6/9 vision. This is his pre-silicone oil removal. This is post-silicone oil removal and post-endophthalmitis also. Remember, this patient after SOR presented like this. So there was a disaster, and patient and his entire family was after my life. What happened? You told it's a trivial procedure, small procedure. It will not take much time, but anything can happen. So you have to be prepared. But moral of the story here is, irrespective of a holiday or a Diwali day or whatever it may be, you have to act very fast. And as Gopal said, do not panic, but act on the enemy. So this is the summary of this. I traced all the slides for him, the GRT patient. This was one lady who had already received multiple interval injections and presented to me with corneal abscess, and PLPR was, doubtful. So this patient here also prompt treatment is required. It's not only intrathecal antibiotics that we say early, but even here also you cannot wait for vitrectomy for a long time. So we did a 3-port vitrectomy in this patient, and the usual ports we made, then made a stab incision to inject visco to protect the endothelium, then started teasing with the help of a bent 26 gauge needle in the pupillary area, to clear this fibrous membrane because you can't enter inside the vitreous cavity without clearing the anterior chamber. The first and foremost task always is to clear the anterior chamber. And once this was done, the IUL also got mobilized in the process and this was taken out. This IUL had one of the haptic which was missing, meaning thereby this patient had had some eventful surgery. This was the IUL which came out. And then we did a depression vitrectomy, sutured the wound. Ultimately, this patient, I had to put silicone oil. And this was the result after a couple of weeks. This was the corneal abscess which got converted into vascularized corneal opacity. This is silicone oil reflexes inside the eye. This was another patient who had had a cataract surgery done and surgeon had put in air bubble there. In this patient, again, a prompt vitrectomy had to be done because patient had already received intravitreal and had a good result. So I'll just describe one of the series of endophthalmitis which I had, which I called a horror show. This was the first postoperative day. 3 silicone oil removals were done. A simple-looking surgery. Often, you leave it for fellows to do. And believe me, all of them were VIPs. One doctor, one advocate, third I don't remember. But this was the end result. On the first post-operative day on a Saturday morning in a busy OPD, I do OPDs on Saturday, who were doing reasonably well, enjoying good vision after complex VR surgeries. And first day, sometimes you can be caught unaware. And especially, once you have a outpatient a department waiting, panic in the entire hospital, more than, what to do at that time. So best is, I isolated this patient, took them to the second floor of my center because there are a lot of panic there. So talk and talk. Took all the relatives, spoke to them that how this can happen. This can happen upon a trivial procedure also. Anything, whenever there is a cut inside the eye, you can develop endophthalmitis. So, but I told them in case you cooperate, we will try to, cancel all the OPD and first priority is to deal with all these patients of endophthalmitis. So fortunately, they were all, agreeing for that. We gave interval injection to all 3 of them on the same day, but monitored these patients, very, very closely. Fortunately for me, after day 9 or this thing, all of them fortunately improved. So moral of the story again here is to knock the enemy at the door itself. So be patient. Patience is one thing, do not panic. Second is you can take opinion. What I did was I took out the register of the entire hospital, asked anybody else has developed this or not. Then talk and talk with the patient as a relative and make them slightly cooperative because if the patient does not cooperate, suppose these 3 had gone out somewhere, they could have maligned or did anything. But fortunately, since they agreed, then early immediate treatment, which is time-tested interval antibiotics, they did the job and they recovered with excellent vision, all 3 of them. So for me, management of endophthalmitis is just like a first aid. Treatment, whether interval antibiotics or vitrectomy, if not done immediately, can have detrimental, uh, not only to function, but to structure also sometimes. So keywords always are, we suspect and react, but sometimes we do not act very fast. So early prompt treatment, whether antibiotics, vitrectomy or revitrectomy, can have gratifying results, or otherwise you can have detrimental result like this also. You see patient where the intervention has been delayed, you have extension from corneal abscess to scleral abscess and ultimately maybe phthisis bulbi. But early if you do it, prompt management, then all this smile can come back on the face of patient as well as on the face of doctor that you have saved these eyes from phthisis bulbi. So thank you very much for this opportunity given to me.
Thank you very much, sir,